Now the next presenter is Dr. Aaysha Cader. Her presentation is a case of double jeopardy.
Thank you, Dr. Shoaib. Can I confirm that you can see my slides?
Sure.
Okay, thank you. So good evening, everyone, and thank you to the BSCI leadership for the opportunity to present a case. This is a case of double jeopardy, and it was about a 34-year-old boyish gentleman with hypertension and dyslipidemia, but he was not diabetic. He had a history of prior inferior STEMI and was thrombolized a couple of days back in another center, and presented to our center with post-MI CCS class 3 to 4 angina. His ECG was consistent with an inferior STEMI, and additionally, STT changes in the anterior leads, and ejection fraction was around 50% with inferior wall motion abnormalities. We then proceeded for coronary angiography transradially. This is his angiogram, which was a bit unexpected because you would expect that a young chap had a pretty straightforward lesion consistent with an inferior MI. But as you can see, he had a CT of the LAD from its mid part with grade 2 ipsilateral epicardial collaterals extending from a very large diagonal. And this is the infarct-related artery, which is the RCA. It has a Medina 111 bifurcation lesion in its distal part with plaque burden involving the ostia of the PDA as well as the PLV, severity more predominant in the osteoproximal PDA. There are also some faint retrograde collaterals extending to the CTO LAD. So this is essentially a case of double jeopardy, and that is essentially the concurrent presence of a non-infarct-related artery CTO, that is a bystander CTO, in this case, the CTO LAD, in a patient who presents with a STEMI where the newly occlusive infarct-related artery, in our case, it would be the RCA, might supply collaterals to the CTO. Therefore, an occluded RCA might result in a large area of subtended myocardium, and that is what essentially a double jeopardy scenario is. This is seen in about a tenth of patients with STEMI, and needless to say is associated with increased morbidity and mortality. And in our case, the ischemic burden of the left system was probably partially relieved by the fact that the collaterals were also ipsilateral. But ideally, it should not be left alone, even in this inferior MI setting. And indeed, the most robust data for a bystander CTO in the presence of STEMI comes from the EXPLORE trial that randomized about 350 patients to CTO PCI versus no CTO PCI in the case of multivessel disease with STEMI, and found that there were no benefits in terms of difference at 4 months between those who underwent a CTO PCI and those who didn't. But there was a signal towards benefit in case of the CTO location in the subgroup analysis, where if the CTO was in the LAD, there was some degree of benefit that was seen in the study. So given what we know about this, we have a non-infarct-related CTO of the LAD. We have a culprit complex true bifurcation lesion of the RCA. So the question of complete revascularization at the same setting or pre-discharge in this multivessel disease of CTO LAD arises. And in our patient, the additional question is if the CTO can be intervened by PCI or not. It's unpredictable if a CTO would open or not, but we decided that it could be attempted first because in this case, the culprit lesion or the infarct-related artery, which is the RCA, is not entirely occlusive, but indeed semi-occlusive with some distal flow. So we also had the option then of complete revascularization by CABG and had the surgical team at hand. So given what we know, we proceeded for PCI to LAD. This was achieved by engaging a jail guide and extending a moderate support Fielder XT guide wire, which required a very small profile balloon support. And as you can see, then the Fielder XT advanced through the CTO segment into the distal true lumen. This was confirmed by the presence of pristine ipsilateral collaterals extending from the diagonal, which is why we did not need a dual injection in this case, and followed by a 1.255 millimeter, that is the same balloon was used where we needed a partial balloon inflation primarily in order to send an IVUS catheter down. And so we did take an IVUS down, which IVUS showed a focal 270-degree lesions of concentric calcium and in a long segment disease, and there was also plaque burden, but of course the diagonal ostium was clear. So that was important in terms of deciding the strategy. So further lesion preparation was then done with a 2 by 15 millimeter NC balloon, given that there was plaque burden and fibrotic calcified lesions within the mid LAD. And the LAD was then stented with a 2.25 40 millimeter drug-eluting stent sized according to IVUS, sparing the diagonal ostium. This was then post-dilated, and we did a post-stenting IVUS, which revealed well-opposed stent struts in the mid LAD where it was stented and a clear diagonal ostium at the end. So one jeopardy was resolved, and we decided then to tackle the bifurcation lesion, the distal RCA. In this case, given that it was bifurcation lesion, we took a 6 French JR guide catheter and 2 workhorse wires. And the ostial PDA was then pre-dilated because that was the more tighter lesion with the 210 NC balloon. After we then took IVUS catheter, and this is the IVUS image pullback from the PDA as well as the PLV with plaque burden. And so given that the ostia were involved, this is a true bifurcation lesion. So should we go for an upfront 2-stent strategy? And given what we know. And among the 2-stent strategies, which technique might be able to adapt from among the typical 3 musketeers of DK crush, culotte, or tap? So we know that all of them would involve some degree of procedural complexity. And considering this suspicious polygon of confluence, we preferred to go for a nano crush, although indeed any of the 3 techniques might be applied here. And this was decided because the nano crush technique is procedurally less complex. It can be done in all bifurcation angles. And we needed to consider the fluoroscopy effect as well as contrast in this case of multivessel disease, particularly as we had already just opened a CTO. So in proceeding with a nano crush, we took a 2.512 millimeter drug-eluting stent, placed it in the side branch, which we would call the PDA here, and had a small 2.515 NC balloon in the main branch, which was then inflated. The side branch stent was then pulled back towards the main branch to ensure a slight protrusion within the main branch and deployed at high pressure. Following this, both the balloons were deflated, and then the side branch balloon was pulled back into the main branch so that half of it was in the main branch, half in the side branch, and this was then inflated in order to open the side branch ostia nicely. And then the side branch stent edge was crushed by the main branch balloon inflated at high pressure. This was followed by the first kissing balloon inflation involving the main branch balloon and the side branch stent balloon at around 12 to 14 atmospheres, after which the side branch stent balloon as well as the wire were removed, and the main branch was then stented, that is the RCA to the PLV, with a 3.518 millimeter drug-eluting stent at 14 atmosphere. This was followed by a pot with a short NC balloon at high pressure. The side branch was then rewired, and this was followed by the final kissing balloon inflation, again with 2 non-compliant balloons at 12 to 14 atmosphere, followed by a bigger final pot by a 410 NC balloon. And we did an IVUS pullback from the PLV to the RCA as well as the PDA to RCA, revealing satisfactory well-opposed stents and very nice polygon of confluence in terms of the bifurcation stent struts as well. And this is the final angiographic picture, which was satisfactory. And not to forget that about 175 mils of contrast was used in the entire procedure. So the takeaway points from this case is that there's complete revascularization in this case of double jeopardy. So despite the fact that there's some non-consensus regarding the revascularization of a bystander CTO, complete revascularization in this case was justifiable in the context that hemodynamic and clinical context permitted it. Furthermore, it's important to consider decisions of which vessel to revascularize first. In our case, because the RCA, which was the infarct-related artery, was not entirely occlusive, we decided to make an attempt of the CTO LAD first. And of course, as we mentioned, a good ejection fraction with less hemodynamic instability on board helped us in terms of completing the case uneventfully, so we lucked out there. Imaging guidance here was crucial in decision-making regarding the strategies. First, in the CTO of the LAD to not stent across the diagonal. Secondly, to find that there was plaque burden involving the ostia of both side branches and go for an upfront 2-stent strategy in the distal RCA. And the CTO LAD antegrade wire escalation approach helped us simplify the case. Nano crush has less procedural complexity than the typical 3 techniques that we know as an upfront 2-stent strategy, and has good real-world outcomes. And finally, it's also important to consider the ancillary aspects of PCI, like contrast volume and radiation limits when revascularizing multivessel disease. So with that, I'll stop. Thank you for your attention. And I'd like to acknowledge my consultant, Professor Said Rahman Khan, with whom I had the opportunity to assist and learn from this case.
Thank you. Thank you, Aaysha Cader. Next case presenter, Mohammad Minaz Arifin.
Aaysha, can I have a question for you?
Yes, please, sir.
2 minutes.
Sir, yeah, you can finish in 2 minutes, okay, sir?
Yeah, okay. regarding the bifurcation of RCA, as it is an infarct-related artery, and the lesion, the PDA was confined within 5 millimeter of the ostium of the disease. So could you have thought about a provisional strategy, the stenting from RCA to followed by a kissing balloon dilatation? Could you have thought about it?
I agree, sir. That was probably an option, and it might have been what we would have gone for if the IVUS didn't reveal that there was significant plaque burden in the ostial PLV as well. And that is why we actually opted for the least complex of the techniques, which would involve minimal radiation, minimal extra contrast, and instead use the nano crush, because you don't need to rewire twice, unlike DK crush. And you never lose the side branch in nano crush. The wire is always present there. So with these advantages and the ancillary advantages of less complexity, we therefore decided to go for nano crush in this case. But of course, if it was
actually the cost is an issue as well. In an infarct-related artery, if you can save the cost of one stent, it is quite significant for majority of the patients as well, isn't it?
Yes,
yes, sir. Martin, sir, it is really in infarct-related artery. It is always wise to make the procedure simple. And Dr. Aaysha, thank you for nice presentation. It is a really good case, young patient, LED CTO. But after wiring the LED, you predilate with 1.25 balloon first.
Yes, because we went with 1.255.
Then you took the IVUS catheter, yeah.
Yes. Otherwise, probably the IVUS wouldn't have crossed.
On query, just for infarct-related artery, we used to do the infarct-related. We used to tackle the infarct-related artery first. Then we usually go for the other artery. But you did it in a reverse way. What was the reason?
Yes. So the explanation for that is that this was not a primary PCI per se. First of all, it was a patient who was thrombolized with essentially TIMI3 flow. It was pharmacoinvasive, essentially TIMI3 flow into the distal RCA. If he came with a STEMI, then and it was primary PCI, we would have definitely gone for the RCA first. But given that this was pharmacoinvasive and it was,
all are
take a chance with the LED first. Yeah.
So for RCA, which size catheter did you use? Was it 5 French?
No, RCA was 6 French because it's bifurcation. We would have to use the 6 French. Yes.
And for left, it was 6 also.
And the left was actually 5 because Saidusar does a lot of slender CTO, and so we went with the 5 French.
He frequently used 5 French for CTO also, yeah? Yes, I am actually afraid to use 5 French in CTO case. I don't know what hardware we may need. So always at least 6 French and sometimes 7 also. Thank you. Thank you for great presentation.